as healthcare and medical care move towards paying for outcomes, the measurement of these outcomes becomes paramount, and that's the process we're engaged in. So let me say a little about how these distinctive or commendable or acceptable thresholds might be identified. How would you know if you're in one category versus another? How well do you have to do, et cetera? And the basic concept is unacceptable is sort of, we really just don't think a nursing home ought to get any performance metric if it's below, if you have one of those basic clinical metrics that are below a certain level. So, obviously, first principle that we talked about, don't set a target that's unreachable. So we wouldn't anticipate that distinction would be unreachable by facilities, and when we get to HCBS, that either for them, and that would be likely an absolute level. Not, for example, saying if you're in the bottom 25%, you're unacceptable. Well, then the bottom 25% never catch up, right? So that would be an inappropriate way for us to establish a threshold for unacceptable, because then you have a quarter of your facilities that are always below the threshold, no matter how well they do. So that's likely to be an absolute target of performance. One possibility for distinguishing between acceptable and commendable, 1 point versus 2 points, and then when they're added up, one level of incentive versus another, is to choose another absolute level. We could pick that absolute level by looking at national data and saying, look, at the national level, 50, 25, 10% of the best 10, 25, 50% of nursing homes achieve X. And we could say arbitrarily, and if we did it that way, it'd be arbitrary, that's what gets you in the commendable threshold. So you could pick an absolute level of performance, and the key, even if that absolute level was selected because it relates to, a percentile score at the national level, the key is it's a number that you can shoot for, and you know it in advance. Before the year has even begun, if you hit that level of performance, you can be in the commendable category. And that's what we're shooting for. That beforehand, you would know what it takes to be acceptable. You would know what it takes to be commendable. The reason I've gone through all that trouble is that's not how we're going to recommend the highest level of performance, exemplary, distinctive. That you wouldn't know in advance, because we're recommending sort of the default plan here is that really is, after all is said and done, the top X percent. We're thinking 5 or 10%, the top X percent of performers, and we can't tell you what that is in advance, right? We would know that in the end. So I'm just going to very quickly revisit. The difference between acceptable and unacceptable is a specific number where we collectively make a clinical and value judgment as to what a minimum level of performance should be. You know that in advance, and it may be that we hope 100% of our providers meet that. Ideally, they do. The level between acceptable and commendable, higher levels of incentive, would be a fixed number that we pick in advance, but we might pick that number because it's let's say, 25th, it's the top 25% nationally. But it doesn't float around, you know what it is in advance. The distinctive level would be that after the fact, the top, let's say 10% worth of performers. And that's both a competitive and an absolute target.
Okay, so if 2A is the floor, then how is B acceptable, get an extra point? if you're acceptable at A, how are you, we're going to have to change some terminology somewhere.
We could start at 0, we could start at 9. And you're pointing out correctly that you're really not even...
Yeah, it's not much of a competitor. I'm a competitor, and that's not much competition to get to acceptable. I want
Correct.
number 1 to be commendable.
Correct. So so getting to acceptable is not designed to be competitive. What we haven't done, and we would take certainly input on, should there be an enormous or a minute difference in the amount of payment incentive that was actually granted between acceptable, commendable, and distinctive. You get a few pennies per day for acceptable, you get $1 a day for commendable, and it's $100 for for distinctive. Is it amount more or less that is sort of $1 or an amount of money per point? In which case you're sort of staking everybody with 9 if they meet the minimum thresholds in all of those categories. Any thoughts before we move on to the sort of explore HCBS here for a minute?
It seems like the methodology may have changed. Is that correct? Or because here you're kind of ranking the facilities and seeing what the state's distribution is.
So let me rephrase that. In order to meet the acceptable and commendable, those will be fixed hard targets of performance, not relative to peers, but the distinctive classification at a higher level of incentive would be that comparison to your peers in the state. That's the distinctive class, which is most directly a comparison to other providers in the state. It could also, this is complicated, but it could also be that we identify a performance level for commendable, which is based on data that we observe in the state. I think all of these thresholds are likely to be based in part on our looking at data in the state.
In previous works group, you talked about maybe a combination of both, that the facility would be compared to themselves, kind of like a relative improvement, and then also that the facility would be compared to their peers. So that was just, I know it was just brought up. Sounds like the methodology has changed.
Is that still
that
true?
aspect.
We just it's not depicted here. We became overwhelmingly complex was the feedback we got, and so we took one of those complexities out. Good, nice catch. Let me go to the next slide to show where we're, at least structurally, what we're thinking about for HCBS metrics. I almost hesitate to put the slide up because I don't think we're anywhere near having measures. This just depicts the categories that we want to fill in with performance metrics on the HCBS side, but this is very difficult, and so we're nowhere near. This is not our recommended list of metrics. It's really the recommended list of categories, and that's actually taken from kind of the Medicaid waiver review criteria. And you all have seen this before. So the 4 are 6, level of care, service plan, provider qualifications, health and welfare, financial accountability, and administrative authority. And you can see some examples. We really feel like these are pretty heavily process-oriented. They're not outcome-oriented. I don't see here, for example, the relevance of the in-home worker and provider to an individual's overall health. And I personally won't be satisfied until I see that one way or the other, and it's not here. And that's an outcome measure. It's a coordination issue. It's reflected on the nursing home side with hospital readmissions to lower those. reflects an input and a coordination, both input at the nursing home level, likely coordination with medical providers, and we don't yet see that here on the HCBS side. We've really already gone through the time frames. I think we already had a good conversation about time frames, and I think that chart that we looked at first was actually a little more useful than the list you see here, but this sort of spells out some of the more practical milestones that we have to meet in order to succeed with payment reforms between now and next July. Questions and comments in general on anything that we've talked about today? We have a specific ask for your comments and input on the basic methodology for case mix adjustment, on quality metrics, especially for the HCBS side.
Once facilities have been placed into these categories, will that information be available to the public?
I assume that one way or another it could be obtained by the public. It won't include those facility level metrics. Will not include personal health information. So the reports to providers will likely include personal health information. But I must tell you, I assume that one way or the other, that data could be obtained through public information requests. We don't currently have a plan for consumer reporting. That's true also on the medical episode side. We have to redact quite a bit from the provider reports because what we also provide we include in our reports to providers information on specific patients, partly as a quality improvement process for the reports, and to make sure that a provider can crosswalk their own records with what we're using to calculate the just transparency of the provider, and to provide insight to the provider on individual patient experiences to help diagnose a problem that they see in their own performance or opportunities for improvement. But that is personalized, and we have to redact that when we get requests. We don't currently have a plan for making all of this available directly to consumers. Frankly, we're focused on the operational challenges of just making it available to providers. But it could be obtained through Freedom of Information, and sometimes is for the medical episodes. Did you have a further comment on whether that's good? That would be... Well, no, honestly, would you prefer that we provide that to consumers, or is that something that you'd like?
I think the public deserves to know if they've got 3 nursing homes in a community and one's acceptable and one's distinctive. I think the public deserves to know that, and they shouldn't need to request a Freedom of Information to get that information.
Brett and Mary, any last comments before we move on here?
No, we're fine. Thank you, Andy.
Thank you for your participation.